Hi everyone, this is Morgan Reinig from the New England QIN-QIO, and I wanted to thank you for joining us for today's webinar on CMS reporting updates, proposed rules, and the potential financial impacts to hospitals. We are excited to have participants from around New England attending today's webinar. Before we get started, I'm going to review a few housekeeping items. This call will be recorded for training purposes, and I will provide you with details on accessing the recording at the end of the webinar. The phone lines are on mute for the duration of the presentation, but we will be taking questions at the end, and I will provide you with instructions on how to unmute your line at that time. We have been having some phone difficulties. We're not quite sure what's going on, but if the line does drop, please try and call back in. We're obviously crossing our fingers that doesn't happen, because today's presentation is going to be very helpful for everyone. So with that said, I'd like to introduce today's speaker, Jeanne Dufresne. Ms. Dufresne is a Senior Program Coordinator and the Hospital Performance Regional State Lead with the New England QIN-QIO. With a focus on the CMS program, Better Care at a Lower Cost, Ms. Dufresne develops and provides education around the Centers for Medicare and Medicaid's Quality Data Reporting Programs. Ms. Dufresne is an experienced quality improvement data analysis professional with a strong working knowledge and experience with the CMS regulatory programs. She has been responsible for performance improvement activities through the collection and analysis of data as required by individual regulatory programs. Ms. Dufresne earned her certificate in healthcare quality in March 2014. The Certified Professional in Healthcare Quality Certification Program is fully accredited by the National Commission for Certifying Agencies of the Institute for Accrediting Excellence in Washington, D.C. Wow, that's a mouthful. Ms. Dufresne also has extensive experience in the acute care environment with all quality reporting programs. She has been working with CMS reporting for the past 10 years and has assisted acute care facilities across New England with program requirements. With that said, please welcome Jeanne Dufresne.
Thank you, Morgan. What a wonderful introduction I wrote. Good morning, everyone, and thank you for joining the New England QIN-QIO as we walk through several CMS reporting program updates and the potential fiscal impact of those updates on hospitals. My name is Jeanne Dufresne, and I will be your speaker for today's event. During the question and answer portion of our web event, I will be joined by several subject matter experts from the New England QIN-QIO. This presentation will provide an overview of three major CMS reporting programs. The first, Inpatient Quality Reporting, will include a look at the updates to the Readmission Reduction Program, Hospital Acquired Condition or HAC Program, and the Value-Based Purchasing Program. Second, we will look at updates made to the calendar year 2016 Outpatient Proposed Rule, and finally, we will conclude with the now finalized Stage 3 Meaningful Use Program. Please note at the time this presentation was prepared, the Stage 3 Meaningful Use Rule was still in proposal. For today's event, the QIO has responded with a big picture view of some of the changes that will take effect, along with resources for providers. The QIO has also started preparation to host another webinar in November to address this new rule in detail. We will also provide a synopsis, which will be made available on our website. It is our hope that this group will reconvene in November as we focus discussion on the Stage 3 Meaningful Use Rule and how it affects healthcare, in particular, what it will mean for hospitals. At the conclusion of this presentation, it is our goal that participants will have a better understanding of changes to these policies and the importance each program plays in the financial health of a hospital. The objective for today is to provide participants with a high-level working knowledge of the new and proposed data reporting categories relative to the following CMS reporting programs and their impact on hospital reimbursement. The fiscal year 2016 Inpatient Prospective Payment System Interim Final Rule, the calendar year 2016 Outpatient Prospective Payment System Proposed Rule, and the Stage 3 Meaningful Use Program Final Rule. And legally, I'll read this slide. This presentation was prepared as a service to the public and is not intended to grant rights or impose obligations. This presentation may contain references or links to statutes, regulations, or other policy materials. The information provided is only intended to be a general summary. It is not intended to take the place of either the written law or regulations. We encourage readers to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. Well, let's start with the Inpatient Quality Reporting Program. On August 17, 2015, CMS published the fiscal year 2016 IPPS final rule. CMS established new requirements and revisited existing requirements for quality reporting by acute care hospitals that are participating in Medicare reporting, including relative provisions for eligible hospitals and critical access hospitals participating in the Medicare Electronic Health Record or EHR incentive program. CMS has also updated policies relating to the Hospital Value-Based Purchasing Program, the Hospital's Readmission Reduction Program, and the Hospital Acquired Condition or HAC Reduction Program. So key areas of changes for the Hospital Inpatient Quality Program include 7 new claims measures, episodes of payment, excessive days in acute care, and a patient safety culture survey. Also, an expansion in the denominator for pneumonia readmissions, and finally, mandatory electronic measure reporting for core measures. In the fiscal year 2016 final rule, CMS has mandated reporting of 6 new claims-based measures and 1 structural. This is applicable to the hospital IQR program for fiscal year 2018 payment determination and subsequent years. The claims-based measures include AMI and heart failure, excess days, and acute care after hospitalization. Additionally, CMS also finalized the total hip and total knee arthroplasty payment measure for fiscal year 2018. The structural measure, patient safety culture, will assess whether a hospital administers a patient safety culture survey. This structural measure will be limited to 5 questions that can be completed using a web-based tool found on QualityNet and will be completed annually based on the previous calendar year. After consideration of public comments received by CMS, the modifications of the proposals on the episodic payment measures was finalized. CMS finalized the 3 measures as listed on the slide. CMS did not finalize the lumbar spine fusion refusion clinical episode-based payment measure that was in proposal. Also, CMS is postponing implementation of the kidney UTI, cellulitis, and GI payment measures until the fiscal year 2019 payment determination. Hospitals will be provided confidential hospital-specific feedback reports containing performance data on these 3 measures prior to inclusion for public reporting. For 2018, which is calendar year 2016 reporting, hospitals will be required to submit the 8 listed chart-abstracted measures to meet IQR requirements. In the proposed rule, CMS had considered that hospitals have a choice with this reporting. However, based on public comments, CMS finalized that these chart-abstracted measures will be required for the entire year based on the chart-abstracted deadlines for fiscal year 2018 payment determinations. Timelines for reporting can be found on the QualityNet website. CMS finalized the removal of chart-abstracted versions of Stroke 1, Stroke 6, and Stroke 8, BTE 1, BTE 2, BTE 3 on the basis that these measures are topped out. However, Stroke 6 and 8 and BTE 1, 2, and 3 will be retained as electronic clinical quality measures to align the hospital IQR and EHR incentive programs. Because performance on the AMI 7A measure does not result in better patient outcomes, CMS has finalized its removal as a chart-abstracted measure. CMS also believes the burden for hospitals to report data on this measure with only a few facilities that have enough cases to be publicly reported outweighs the benefit of retaining the chart-abstracted version of this measure. However, CMS will retain AMI 7A as an electronic clinical quality measure in order to align the hospital IQR and EHR incentive programs. CMS is removing item M1 from the hospital IQR program due to the continued infeasibility to implement and align this measure with current clinical guidelines or practice. CMS also finalized the removal of SCIP-Int4 as the measure does not result in better patient outcomes, does not align with current clinical guidelines or practices, and public reporting of this measure leads to negative or unintended consequences in patient health. So a look at the refinement to the pneumonia readmission measure and the expansion of the measure cohort. And this is for fiscal year 2017 payment determination. Within the hospital readmission reduction program, CMS has finalized the expansion for this measure. The current pneumonia measure includes patients with a principal discharge diagnosis of pneumonia. CMS has modified this to now include patients with a principal discharge of aspiration pneumonia and also patients with a principal discharge diagnosis of sepsis with a secondary diagnosis of pneumonia. The principal discharge diagnosis of sepsis excludes severe sepsis. Also excluded from this modification are patients with a principal diagnosis discharge of respiratory failure with a secondary diagnosis of pneumonia present on admission, or patients coded as having severe sepsis or sepsis shock. This slide reflects now current readmission measures included in the hospital readmission reduction program. For fiscal years 2013 and 2014, conditions included in the readmission reduction program were acute myocardial infarction, heart failure, and pneumonia. For fiscal year 2014, CMS also established additional exclusions to the three existing readmission measures to account for additional planned readmissions. CMS then included additional readmission measures, chronic obstructive pulmonary disease, and total hip arthroplasty and total knee arthroplasty to be used in the hospital readmission reduction program for fiscal year 2015 and future years. For fiscal year 2017 and future years, patients readmitted following coronary artery bypass graft or CABG surgery are now part of the readmission reduction program. We will now look at the inpatient quality reporting program related to electronic clinical quality measures and the alignment to the EHR incentive program. In response to public comments, CMS modified its proposal to require reporting of 16 out of 28 electronic clinical quality measures down to 4 out of 28 electronic clinical quality measures for calendar year 2016 reporting. CMS does believe that requiring hospitals to report a minimum of 4 is reasonable because it significantly reduces burden for hospitals from the 16 proposed, but still allows for the collection of data derived from EHR to further plan for electronic data collection and validation. Also, instead of requiring hospitals to report 2 quarters of data within 2 months following the reporting period, as was proposed, hospitals will be required to report the 4 electronic clinical quality measures for just 1 quarter. Hospitals can elect to report either quarter 3 or quarter 4 of the calendar year 2016, with a submission deadline of February 28, 2017. This should allow more time for hospitals to overcome vendor issues such as mapping and testing. Another part to this mandated electronic reporting is that instead of requiring a hospital select and report ECQM measures across the 3 National Quality Forum domains, as was recently proposed, CMS finalized their policy and will not require that any of the 4 ECQMs fall under any particular NQF domain. As a note, CMS is anticipating an increase in the number of required electronic clinical quality measures in future rules to a 16-measure requirement. The belief is that a full year should be enough time for hospitals to address their mapping issues and that it is important to continue to make progress towards electronic reporting. CMS is requiring the use of the most recent electronic measure specification in allowing collection of electronic data. The modified policies, later reporting period, and an extended submission deadline should provide hospitals with additional time to update the most recent measure specification. Hospitals can report electronic clinical quality measures using either the 2014 or the 2015 edition of CERT. The 2015 measure specifications are required regardless of a hospital's decision to use versions 2014 or 16 of CERT. CMS is also requiring reviews of the 2015 CMS Implementation Guide or Quality Reporting Document Architecture Category 1 and Category 3 Supplementary Implementation Guide available on their website. There are 29 electronic clinical quality measures. 28 of these are available to be submitted for the Hospital Inpatient Quality Reporting Program. ED3 is an outpatient measure and therefore not applicable for submission to IQR. CMS will continue to retain a variety of electronic ECQMs in order to ensure that hospitals have flexibility and choice in determining which electronic measures to report. The idea is that collection of electronic clinical quality measure data will enable hospitals to efficiently capture and calculate quality data. CMS recognizes that there may be special circumstances that do not allow a hospital to submit ECQMs. Such hardships could include, but are not limited to, infrastructure challenges such as insufficient internet access or unpredictable instances such as vendor issues outside of the hospital's control. In addition, hospitals newly participating in the hospital IQI program may also be considered undergoing hardship. CMS has finalized a policy that allows hospitals to use the existing extraordinary circumstance exemption form to request an exemption from the hospital IQI program ECQM reporting requirement for the applicable program year based on hardships. CMS will also allow hospitals to apply the zero denominator and case threshold exemption as described to the fiscal year 2015 IPPS final rule. CMS will be further educating hospitals in the December-January timeframe and will issue frequently asked questions to provide clarification on deadline dates, scenarios, etc. Also, important to note, any data submitted electronically will not be posted on the Hospital Compare website. Public reporting of electronic data will be addressed in next year's rulemaking following the conclusion and assessment of the ECQM validation pilot. This slide that I shamefully stole from the Association of the American Medical Colleges is a great visual of where we are currently and where CMS reporting is moving to. As you can see by the diagram on the left, the Meaningful Use EHR program mandates either attestation or electronic reporting by a provider. Next to that, the IQR program mandates voluntary electronic reporting or chart abstraction. Unlike the Meaningful Use diagram, where the reporting time period is similar, the IQR reporting time period is different depending on the venue a hospital chooses to report. In the future reporting diagram on the right, both the Meaningful Use EHR program and the IQR program is simplified. One way to report with one time period. Now a discussion and review on pertinent changes to the Hospital-Acquired Condition Program that were finalized in the fiscal year 2016 final rule. This slide is an overview of the HAC reduction program measures that have been finalized in prior rules. In fiscal year 2016, the HAC reduction program included the addition of the surgical site infection measures. For the 2017 HAC reduction program, CMS plans to extend the measure set to include MRSA and C. difficile. In the final rule, there are no proposed changes to policy that were previously implemented in the HAC reduction program for fiscal year 2016. However, the ARC PSI 90 composite measure is undergoing National Quality Forum maintenance review. During the review, ARC is considering revisions to the composite that includes the addition of three measures: PSI 9 postoperative hemorrhage or hematoma rate, PSI 10, postoperative physiologic and metabolic derangement, and PSI 11, postoperative respiratory failure, or a combination of these three measures. In addition, the CDC NHSN potty and CLABSI measures completed the NQF maintenance review process. During the process, the National Quality Forum re-endorsed a modified version of the measures that include the ARM, or Adjusted Ranking Measure, which is a new statistical action for calculating the measure result. Although this version was endorsed by NQF, it is important to note the HAC reduction program is currently working to determine the appropriateness of using the ARM versus the SERP and will not make any decisions regarding the utilization of the ARM until CMS gathers additional information. Also finalized is the applicable time period for the fiscal year 2017 HAC reduction program. The Domain 1 PSI 90 composite measure time period will be from July 1st, 2013 through June 30th, 2015, and weighted at 15%. For the CDC NHSN measures, CLABSI, potty, SSI, Mercer, and C. difficile, the applicable time period will be calendar years 2014 and 2015, and weighted at 85%. With the implementation of the CDC MRSA bacteremia and CDI measures in the fiscal year 2017 program, CMS believes the weighting of both domains need to be adjusted to reflect the addition of the fifth and sixth measure in Domain 2. CMS also revised their approach on how they will calculate the Domain 2 score. In the current rule, a score is assigned for each Domain 2 measure, and then the measure scores are averaged. In the fiscal year 2016 final rule, each Domain 2 measure will be treated independently when determining if a score of 10 should be assigned to the measures. An example of this would be if a hospital does not submit data for the colon and abdominal hysterectomy SSI measure and does not have a valid waiver for non-reporting, the measure would receive a score of 10. This will affect the entire Domain 2 score. And moving right along, a look at updates to the Hospital Value-Based Purchasing Program for fiscal year 2016 and subsequent years. In the fiscal year 2016 IPPS final rule, CMS finalized the addition of the CTM3, the three-item care transition measure. This increases the total age caps dimension, measured from 8 to 9. Two measures removed for fiscal year 2018 were AMI 7A and IMM2, formerly under the clinical care process domain. The remaining measure in the clinical care process domain, the PCO1 measure, was moved to the safety domain. The MAP hospital work group has included PCO1 as an obstetrical adverse event measure in its safety family of measures. Due to this, CMS felt it appropriate to move this measure to the safety domain. Because there were no measures remaining in the clinical care process subdomain, CMS finalized the removal of that subdomain, and the clinical care domain now only includes the three 30-day mortality measures. Minimum requirements for the Hospital Value-Based Purchasing Fiscal Year 2018 program. The requirements include 100 age gap surveys within the patient and caregiver-centered experience of care coordination domain, 25 episodes of care in the Medicare spending for beneficiary domain, 2 mortality measures with a minimum of 25 cases in the clinical care domain, a minimum of 3 cases for any one underlying indicator within the ARC-PSI 90 program, 1 predicted infection within the HAI measures program, and 10 cases from the PCO1 reporting program, all of which make up the safety domain. A minimum of 3 of the 4 domains receiving domain scores is needed to make up a hospital's total performance score. This is a very busy slide, and again, I want to just point out the data source for this was from a CMS web event they held in September. And this very busy slide is meant to alert hospitals to CMS's intent to propose inclusion of select ward non-ICU locations in certain NHSN measures to be included in the hospital value-based purchasing program beginning with fiscal year 2019. In the 2016 fiscal year final rule, CMS motioned their intent to propose including select ward or non-ICU locations in the cardiac biopsy measures beginning with the fiscal year 2019 program year in future rulemaking. CMS intends to propose to adopt the baseline of January 1st, 2015 through December 31st of 2015 and a performance period of January 1st, 2017 through December 31st of 2017 for cardiac biopsy measures. This expansion of cardiac biopsy measures would be consistent with the National Quality Forum re-endorsement update to these measures, which allows application of measures beyond ICUs. CMS feels the expansion of measures will allow hospitals that do not have ICU locations to use tools and resources of the NHSN for quality improvement and public reporting effort. Again, another very busy slide. This slide shows and explains the Hospital Value-Based Purchasing Program NHSN Measures Standard Population Update. I'm going to move through this reading slowly. The NHSN measures are calculated by the Centers for Disease Control and currently include the cardiac biopsy, bacteremia, CDI, and colon and abdominal hysterectomy SSI measures in the fiscal year 2017 and subsequent program years. They measure the occurrence of these HAIs in the hospitals participating in the Hospital Value-Based Purchasing Program. Beginning in 2015, CDC started to collect data in order to update the new standard population data for all of these NHSN measures. The fiscal year 2015 standard population data for HAI measures will now be referred to as the new standard population data. Because value-based purchasing calculates improvement points using comparisons between data collected from hospitals and a baseline period and data collected in the performance period, value-based purchasing must treat CDC's standard population data updates differently than other quality programs. CMS has determined they cannot equally compare CDC's new standard population data to the current standard population data in order to calculate improvement points. If not addressed, then CMS would be unable to compare the baseline and performance period for the NHSN measures in fiscal year 2017 and fiscal year 2018 program years. In order to address the problem, CMS will use the current standard population to calculate performance standards and to calculate and publicly report measure scores until the fiscal year 2019 program year. For fiscal year 2019 and subsequent years, value-based purchasing will use the new standard population data to calculate performance standards and to calculate and publicly report measure scores. The scoring methodology for a hospital value-based purchasing for fiscal year 2018 program year was finalized in the fiscal year 2016 final rule. In the final rule, CMS continued the adoption of the 4 domains listed on this slide. Each of the domains for the fiscal year 2018 program year will be equally weighted at 25% of the total performance score. CMS policy also states that a hospital must receive scores in at least 3 of the 4 domains in order to be eligible to incur payment adjustments under value-based purchasing. This is a reference slide for the fiscal year 2018 Hospital Value-Based Purchasing Program and the adopted baseline performance periods. The clinical care domain, containing the 30-day mortality measures, has their baseline periods of October 1st, 2009 through June 30th, 2012, and a performance period of October 1st, 2013 through June 30th of 2016. The Outpatient Safety Indicator, PSI 90 Composite, in the safety domain has a baseline period of July 1st, 2010 through June 30th, 2012, and a performance period of July 1st, 2014 through June 30th, 2016. The remaining domains and measures utilize a baseline period of January 1st, 2014 through December 31st, 2014, and a performance period of January 1st, 2016 through December 31st, 2016. Although this change does not go into effect until the fiscal year 2021 value-based purchasing program, I thought it worth bringing to everyone's attention. Initial measure data for the hospital 30-day all-cause risk standardized mortality rate following chronic obstructive pulmonary disease hospitalization was posted on Hospital Compare in December of 2014. CMS has finalized the addition of this measure to be included within the clinical care domain for the fiscal year 2021 hospital value-based purchasing program year. We will now review the CMS proposed outpatient calendar year 2016 rule as it pertains to hospitals. There was not a lot of proposed changes to the outpatient rule. I do not anticipate spending too much time on this topic. CMS proposes to add two new measures. OP33, external beam radiotherapy for bone metastasis, EBRT, and OP34, emergency department transfer communication, or EDTC. CMS is also proposing to remove OP15, use of brain computed tomography in the emergency department for atraumatic headache. CMS is also exploring whether in future rulemaking a proposal that hospitals have the option to voluntarily submit OP18, median time from ED arrival to ED departure for discharged ED patients as an EC2M. That is something we will keep an eye on. OP33, external beam radiotherapy for bone metastasis, or EBRT. This proposed measure looks at the percentage of patients, all payer, with painful bone metastasis and no history of previous radiation who receive external beam radiotherapy with an acceptable dosing schedule. This measure is supported by the Measure Applications Partnership, or MAP, and addresses the National Quality Strategy priority of making care safer. This web-based measure is proposed for calendar year 2018 payment determination. And again, the intention of this measure is to assess the percentage of patients who receive acceptable doses of external beam radiation therapy. There will be two submission methods available. The first is via the CMS web-based tool or the QualityNet website. And the second, submit an aggregate data file for this measure through a vendor using the QualityNet infrastructure. The data submission deadline for either reporting method would be May 15th. This measure, if finalized, will begin with January 1st, 2016 patient encounters. A link to detailed specifications can be found at the conclusion of this presentation. OP34, Emergency Department Transfer Communication, or EDTC. This proposed measure looks at the percentage of patients transferred to another healthcare facility whose medical record documentation indicated that administrative and healthcare information was communicated to the receiving facility in a timely manner. This measure includes 7 subcomponents consisting of 27 distinct elements. The 7 subcomponents are administrative data, patient information, vital signs, medication, physician information, nursing information, and procedure and test results. This web-based measure is being proposed for calendar year 2019 payment determination. Again, the intention of this measure is to assess the percentage of patients transferred to another facility whose medical record was communicated to the receiving facility. There are 2 submission methods, same as OP33, via the CMS web-based tool or QualityNet, or submit an aggregate data file through a vendor using the QualityNet infrastructure. The data submission deadline for either reporting method would be May 15th. This measure, if finalized, will begin with January 1st, 2017 patient encounters. And again, we have a link to the detailed specifications at the conclusion of this presentation. There was also a correction made. OP4 aspirin at arrival was inadvertently excluded from the Federal Register from the tables on pages 39329 and pages 39334. OP4 should be included in the measure sets for the calendar year 2018 and calendar year 2019 payment determination and subsequent years. CMS will clarify this in the final rule. Fiscal impact, inpatient quality reporting. So what exactly is at risk to a hospital's financial health? And the reason I'm picking on the IQR program is that the majority of the fiscal impact of these reporting program lies within the inpatient quality reporting program itself. The Electronic Health Records, or EHR incentive program, established incentive payments from fiscal year 2011 to fiscal year 2015 for hospitals who were meaningful users of EHR. However, those incentive payments began to decrease in 2014. Beginning in fiscal year 15, hospitals that are not meaningful users of certified EHR technology will be subject to payment adjustments by 1/2 of the market basket update in fiscal year 2016. The market basket increase is 2.4% for fiscal year 16. The attestation period for the fiscal year 2015 program year will be accepted for all eligible hospitals, eligible professionals, and critical access hospitals from January 4th, 2016 to February 29th, 2016. Within the readmission reduction program, hospitals can either maintain full payment levels or be subject to a penalty of up to 3% of their total DRG reimbursement. The definition of a hospital's excess readmission ratio is the measure of a hospital's readmission performance compared to the national average for the hospital set of patients with the same condition. This includes adjustments of factors that are clinically relevant, such as patient demographic characteristics, comorbidities, and patient frailty. Also, CMS uses an applicable period of 3 years of discharge data and a minimum of 25 cases to calculate a hospital's excess readmission ratio of each relevant condition. The hospital readmission reduction program period will be the 3-year period from July 1st, 2011 through June 30th, 2014. The hospital acquired condition or HAC reduction program applies a 1% negative payment adjustment to hospitals that rank in the worst performing 25% of all subsection D hospitals with respect to HAC quality measures. The total HAC score is based on quality data grouped in 2 domains. Domain 1, the Agency for Healthcare Research and Quality, or AHRQ, Patient Safety Indicators, and Domain 2, the National Healthcare Safety Network, or NHSN Healthcare Associated Infection Measures. The value-based purchasing program is different from the reporting programs just mentioned, in that it is a value-based incentive program that allows hospitals to earn back money for inpatient acute care services based on the quality of care and not just quantity. The program uses the hospital quality data reporting infrastructure developed for the hospital inpatient quality reporting program. The fiscal year 2016 value-based purchasing program will be funded by a 1.75% reduction in IPPS payments for hospitals that meet the program eligibility criteria compared to a 1.5% reduction in fiscal year 2015. Hospitals can earn back some, all, or more than their 1.75% reduction. And the annual percentage update, or the APU. Unlike the very specific programs within the hospital inpatient quality reporting program, the annual percentage update, or APU, is applied to all reporting programs. This includes not only inpatient reporting, but outpatient reporting, and for hospitals that participate in the inpatient psychiatric facility reporting program. Hospitals that are eligible for the IQR program, the OQR program, and the IPSQR program that do not submit quality data could potentially see a 2% decrease per program in their total DRG reimbursement. And finally, we're going to take a look, a very, very high look at the final 3 final stage 3 rule for the EHR program. As I mentioned before, this presentation was completed as a proposed rule and is now a final rule. And this final rule with comment period specifies the requirements that eligible professionals, eligible hospitals, and critical access hospitals must meet in order to qualify for Medicare and Medicaid electronic health record incentive payments and avoid downward payment adjustments under the Medicare EHR incentive program. In addition, it changes the Medicare and Medicaid EHR incentive program's reporting period in 2015 to a 90-day period aligned with the calendar year. This final rule with comment period establishes the requirements for Stage 3 of the program as optional in 2017 and required for all participants beginning in 2018. The final rule with comment period continues to encourage the electronic submission of clinical quality measure, the ECQM data, establishes requirements to transition the program to a single stage, and aligns reporting for providers in the Medicare and Medicaid EHR incentive programs. The CMS rule establishes the requirement providers and hospitals must meet to obtain a Medicare or Medicaid incentive payment through Stage 3 of the Meaningful Use program set to begin in 2017. The CMS rule also makes the first year of Stage 3, 2017, optional. The 2015 edition Health IT Certification Criteria final rule builds on past editions of adopted Health IT certification criteria and includes new and updated IT functionality and provisions that support the EHR incentive program's care improvement, cost reduction, and patient safety across the health system. A second rule from the Office of the National Coordinator for Health IT establishes the criteria for electronic health records to be used by the providers and hospitals meeting Stage 3 requirements. Both rules will be published in the October 16, 2015 Federal Register, and the agencies will accept comments on the final rules until December 15th. After receiving some 2,500 comments from industry stakeholders on the two proposed rules, CMS made some big changes to the regulations. Give providers and state Medicaid agencies 27 months, or until January 1st, 2018, to comply with the new requirements and prepare for the next set of system improvements. Give developers more time to create the next advancements in technology that CMS says will be easier to use and more appropriate to new models of care and access to data by consumers. Support provider exchange of health information and interoperable infrastructure for data exchange between providers and with patients, and address health information blocking and interoperability between providers. CMS is adopting a transition toward a new streamlined set of requirements, again including an optional year for any provider who chooses to attest to the objectives and measures for Stage 3 for an EHR reporting period in 2017. Additionally, CMS is finalizing the objectives and measures that will be required for all eligible providers, regardless of prior participation in the Medicare and Medicaid EHR incentive programs, for an EHR reporting period in 2018 and subsequent years. Through the new requirements of the EHR incentive program, CMS will expand meaningful use of certified EHR technology to promote health information exchange and improved outcomes. This rule includes changes to the structure of the EHR incentive programs, again, to improve efficiency, effectiveness, and flexibility. Major policy provisions include program modifications to reduce reporting burden, eliminate redundant and duplicative reporting, and to better align the objectives and measures of meaningful use with the Stage 3 requirements. A revised single set of objectives and measures, including a reduction of the overall number of objectives to which a provider must attest. Changes in EHR reporting periods, including a shift to calendar year for all providers, and 90-day reporting period for 2015, and new participants in 2016. Revisions to attestation and payment adjustment deadlines, and again, and this is redundant, optional Stage 3 reporting in 2017. So what are our next steps as the New England QIN-QIO? We will be creating a synopsis of Stage 3 meaningful use final rule. Providers will be notified, and the synopsis available on the New England QIN-QIO website. I just haven't quite read the 700 pages I need to finish. We will also be hosting a follow-up webinar in November to take an in-depth look at the Stage 3 meaningful use final rule and the impact on hospitals. This slide has resources for the outpatient proposed rule, the 2 new outpatient measures that we spoke about, the Medicare and Medicaid electronic health records incentive program Stage 3 in the Federal Register, along with the final rule fiscal year 2016 IPPS. I added another slide with even more Stage 3 meaningful use resources. And that concludes our web event.
So, thank you, everyone. Thank you, Jeanne. That was absolutely wonderful. We did have a few questions come across in chat, so I think we'll start off with those before opening the lines for any additional questions. In the beginning, Jeanne, someone asked, can you explain how VTEs 1, 2, and 3 will be collected electronically? Will hospitals be able to still collect these measures by chart abstraction for our internal reporting?
CPE 1, 2, and 3. Let me just go back a little bit. Morgan, stay with me.
Okay.
No, VTE 1, 2, and 3 will not be collected as an abstracted measure. They've been topped out. However, CMS is retaining those measures as electronic clinical quality measures to align with the hospital IQR and EHR incentive program. So to answer the question, no to chart abstraction and being held to the side for possible ECQM.
Excellent. And then we had another question. Is the Q3 or Q4 requirement looking at strictly reporting, or is the performance also looked at?
Currently, it's the reporting. Performance, not yet. And like I said during the presentation, that's why the ECQMs for that time frame will not be publicly reported. The CMS will take a look at how everyone's doing. So it's not so much, not that you want to score poorly, but it's not so much that, it's more the reporting itself.
All right, those were the main questions we had in chat. We have had a few people ask about getting the PowerPoint for today's presentation, and that is currently available on our website. I'm going to put the link to it in chat, and if for some reason you can't get it there, we will send out an email tomorrow with a direct link to it on our website as well. If there are any questions on the line, please feel free to press star 6 on your phone to unmute your line and ask a question. Again, it is star 6 to unmute your line and ask a question.
Yes, I have a question.
Go ahead.
Okay. For the ECQM reporting, you noted that they can be reported either in Q3 or Q4. Do all 4 of the measures have to be reported together, or could they be split between the 2 quarters?
As far as I know, all 4 have to be reported together in one of the 2 quarters.
Okay, thank you.
You're welcome.
Any other questions? It's star 6 to unmute your line. Well, if we don't have any more questions, I just wanted to wrap up a few more items for you guys. As I mentioned, the PowerPoint is available on our website. I put the link in chat, and you will be getting an email with that link again tomorrow. At that same link, you will be able to find a copy of the recording of today's webinar as well as the transcript from the webinar. It might take a few days to get there, but they'll be up there for you guys. As you close out of the webinar today, the evaluation for today's webinar will pop up automatically on your computer screen. If you could please fill that out, we would greatly appreciate it. It helps us make sure we are providing meaningful programs for everyone. But if you don't have time to fill out that evaluation right now, there will be a link to it in the email tomorrow as well. So again, I want to thank Jeanne for that wonderful presentation, and thank you everyone for attending, and have a great day.